She's a resident of New Delhi and a college student. She presented with pain in the right thigh from last 3 months, swelling over the right thigh from last 2 months, and there was difficulty in walking since last 1 month. History of present illness. She was apparently normal 3 months back when she developed pain in her right thigh, which was insidious in onset, dull aching, gradually progressed in severity. It was non radiating, there was no diurnal variation. It exacerbated on doing movements and was temporarily relieved on taking analgesics. Pain was also associated with difficulty in walking since last 1 month. She also complained of swelling over the right thigh in the upper region, upper right thigh, since 2 months, which was also insidious in onset, and it gradually progressed to the current size. There was no history of any trauma. There is no history of swelling or pain elsewhere in the body. There is no history of fever, weight loss, or night sweats. There is no history of redness, ulceration, discharge over the swelling. There is no history of dyspnea or cough, and there is no history of bone pains apart from the affected limb. Past history, there is no history of any comorbidities. There is no history of drug allergies. There is no history of previous surgeries, biopsies, or radiation. And there is no history of previous malignancies or any other bone conditions. Menarche and obstetric history. Menarche started at the age of 12 years with normal flow of 3 to 4 days of 28 to 30-day cycle. Last menstrual period is not applicable, and she is unmarried and nulliparous. Personal history, she takes mixed diet, has normal bowel and bladder habits. There is no history of any addiction, and there is history of sleep disturbance because of the current problem she is into. And there is no history of any family malignancy. So to summarize my case, she's a 19 years old female who had 3 month history of progressive pain in the right thigh, progressive swelling in the right thigh since 2 months, and difficulty in walking since 1 month.
Yeah. Okay. So, I mean, that's a history, right? If you can just go back to the first slide.
Yes.
Yeah. So we have got pain in the right thigh since 3 months. We've got swelling over the right thigh since the last 2 months. And finally, difficulty in walking since last 1 month. Typically, what you tend to see in in a sarcoma of the extremities, right? Could be a bone, could be a soft tissue sarcoma. So, now let us look at the meaning of some of these histories that you have elucidated. So what is the significance of whether pain or whether swelling comes first?
So if I'm suspecting a sarcoma, and if the sarcoma will originate from the bone, then because of the intramedullary region, there will be pressure. So the pain will appear first, then the swelling will appear. But if it is a soft tissue sarcoma I'm suspecting, then swelling will appear and then the pain will happen later on.
Yeah, so you're absolutely right. So, when it's a bone origin, the pain occurs before the swelling. And when it's a soft tissue origin, the swelling occurs before the pain, right? So that's generally how how you differentiate between bone and soft tissue sarcoma. What about, you've also mentioned, can you go to the history of wrestling illness?
Yes, yes, boss.
Yeah. So you mentioned regarding, no diurnal variation, right? But can you tell me, uh, generally in a bone sarcoma, what is the, presentation of pain?
So in case of bone sarcoma, the pain will not be pain will be dull aching pain, and there will be diurnal variation may happen. It may increase during night time.
Yeah. So uh, osteosarcoma, Ewing sarcoma, all these bone sarcomas, especially, the pain tends to increase during the night when the limb is rested. Okay. So that is the characteristic feature of these bone sarcomas. Now you mentioned that this particular patient, since last 1 month, she has difficulty in walking. What could be the various causes of difficulty in walking?
The first could be because of the pain itself,
Okay.
because of the gait disturbance, she's not able to walk. Other could be
So 10 to 15% of bone tumors present with. Yeah. So I'll just complete that. So you're right. obviously the pain itself can cause difficulty in walking. Also, you have if there's a pathological fracture. Okay,
Okay,
so around 10 to 15% of the cases present with the pathological fracture. If there's joint involvement, there might be difficulty in walking. So more extensive disease, and of course, if there's neurological involvement as well. So if the nerve bundle is involved, there also you can have difficulty in walking. So those four reasons you can when they ask you what could be the causes of difficulty in walking. So yeah, so can we go to the next slide? So this swelling elsewhere, right? You had mentioned swelling elsewhere, so that is very significant. That history. What all you know in the context of a bone sarcoma? What are the important factors? What are we ruling out by asking that negative history there that you can think of?
I'm asking about this history to rule out like if there is the possibility of lymphoma, like it may present with lymphadenopathy, so that can be ruled out. And pain elsewhere or swelling elsewhere in the body can also rule out any metastatic presentation of the disease or any multifocal disease per se.
Yeah. Okay. So you're right. Lymphoma can be ruled out because we know that lymphoma can also present as with bone lesions, right? So generally, if it's a lymphoma, you'll have suprainfradiaphragmatic lymphadenopathy. Of course, skip metastasis. So you can have swellings elsewhere on the same bone that is commonly seen in osteosarcoma. So skip metastasis is something else. Then of course you have distant metastasis to other bones in the body, right? They can also be seen with an osteosarcoma. So lymphoma, skip mets, distant bone mets, and of course there are certain sarcomas that spread to the lymph nodes. Okay, we'll get into that next. That is another cause. Then, of course, these sarcomas can occur in the context of syndromes. So you can have like Ollier syndrome, Mafuchi syndrome, where you might have multiple benign lesions, benign bone lesions, but then one of those benign lesions becomes malignant, right? So like I'll just to summarize again, in lymphomas, skip mets, distant bone mets, if the sarcoma spreads to the lymph node, the sarcoma itself spreads to the lymph node, and in the context of syndromes. So the next question will be, what are the sarcomas that have nodal spread?
Osteosarcoma may have nodal spread, not events.
Just three that comes to your mind.
Bone sarcoma or soft tissue sarcoma.
All sarcomas.
Okay. Then uh, leiomyosarcoma, liposarcoma may present with lymphadenopathy. Osteosarcoma may present with lymphadenopathy.
Yeah. So I'll just give you a very for everyone a simple mnemonic that can help you remember all the sarcomas that spread to the lymph nodes. Okay, so it's called scare. Sorry. So S stands for synovial sarcoma, C stands for clear cell sarcoma, uh, A stands for angiosarcoma, D stands for rhabdomyosarcoma, and E stands for epithelioid sarcoma. So those are the common sarcomas that spread to the lymph nodes. It's a classic, favorite question. So what are the two, rhabdomyosarcoma? I want to ask in particular, what are the two sites of primary rhabdomyosarcoma where you have higher chance for lymph node mets?
Like if the rhabdomyosarcoma of the genitourinary may have lymphadenopathy.
And
Genitourinary and this biliary tract rhabdomyosarcoma may also have lymphadenopathy.
yeah, so if we ask you this question, two sites you have to mention in particular. Okay, paratesticular and extremities. Okay. So
Yeah.
paratesticular can have and extremities can have around 20 to 30% of the cases will have can have lymph node mets, whereas the other sites in RMS, they are not that prone to lymph node metastasis. Okay. So we had discussed earlier regarding skip mets, right? So can you define skip mets as per Enneking? He has given a definition for skip mets.
No, I don't know. Boss.
Yeah. So it is basically another foci of osteosarcoma separated from the primary tumor, by normal tissue. So another foci of osteosarcoma separated from the primary tumor by normal tissue occurring in the same bone or across a joint. Okay, so that's another question that they can ask. And like I mentioned earlier, syndromes associated with multiple bone lesions like Olier's and Mafuchi syndrome. Okay, so what about this fever, weight loss, and night sweats? What is the negative history
So,
we're trying to elucidate there?
so I'm asking about the fever just to rule out any B lymphoma symptoms and also any history of infection, for example, osteomyelitis.
Yeah. Are there certain sarcomas that can present with constitutional symptoms?
Ewing sarcoma is one, can present with constitutional
Yeah,
symptoms.
you're right. Yeah. Okay, so like you said, B symptoms we are ruling out. We are ruling out any chronic infection. Sometimes in a very advanced bone sarcoma, you can have a fungating lesion which is infected, right? Uh, so that's another cause. Then of course, like Ewing sarcoma, around 25% of the cases, like 25% to one third of the cases have constitutional symptoms. So that's what we are trying to rule out with this thing. I won't ask the definition of B symptoms. I think we have discussed that in prior case presentations. Uh, Now, of course, what about redness, ulceration, and discharge?
So redness, ulceration, and discharge may point out any chronic osteomyelitic pathology. First thing, any infection, any abscess or contamination of the lesion.
Yeah. Like you said, could it be an infection? It points more towards the direction of an infection, especially something like osteomyelitis, or it could also denote advanced bone tumor where you know it's extending from the bone, involving the other structures, and it's a fungating lesion that's infected, right? So advanced status, or it could denote infection like osteomyelitis. And of course, what about dyspnea, cough, bone pains apart from the affected limb?
Dyspnea and cough because sarcomas have more propensity for uh, lung mets, so or mediastinal involvement. So asking dyspnea and cough to rule out the same.
And bone pains apart from the affected limb?
Bone pains,
Yeah, so that can denote bone mets, right?
the bone
So,
mets and scale mets.
yeah. So when we look at osteosarcoma, the most common site of mets is lungs, followed by the
Yeah.
bones. Okay.
Bone.
So 60 to 70% of the mets are towards the lungs, 20 to 30% of the mets are to the bones, to other bones in the body. When you come to Ewing sarcoma, what are the three most common metastatic sites?
Lung,
Right?
hello.
Yeah, I can hear you.
Yeah, for in lung mets, then bone mets,
Then one more site that's commonly seen in Ewings. The bone marrow as well. Okay. So,
20%.
yeah. So, with osteosarcoma, it's lung mets most commonly, then bone mets. Having sarcoma, it's lung mets, bone mets, and can also involve the bone marrow. Okay. Now, I'm going to ask you some. So that's in bone sarcomas. When you come to soft tissue sarcomas, once again the lungs are the most common sites of mets. I think we all know that, right? Can you name a soft tissue sarcoma with extrapulmonary metastasis? It is a type of like which type of liposarcoma has extrapulmonary metastasis?
Myxoid type.
Yeah, you're right. So it is a myxoid liposarcoma. Okay, so that can spread to the retoperitoneum, it can spread to the bone, it can spread to other soft tissues in the body. Okay, so now moving on, what is a sarcoma that presents in the skin?
No idea, boss.
I think there's a case report.
Oh, DFSP.
Yeah, so DFSP is dermatofibrosarcoma protuberans. Okay, so that can present as a skin lesion. What about, although we generally don't tend to talk about brain metastasis, there are certain sarcomas that can spread to the brain as well. So, can you name a couple of them?
I think I'll just make a guess. The aggressive ones, maybe alveolar soft part sarcoma
You're right.
and this leiomyosarcoma, LMS.
You're right.
Uh, Mm, synovial sarcoma.
Okay, that can also spread. So yeah, you're right. You're right with those. So leiomyosarcoma, alveolar soft part sarcoma, myxoid liposarcoma that can also spread to other sites. Then angiosarcoma also. Okay, so those are the aggressive ones that tend to spread to the brain as well. Now, uh, can we move on to the next slide? Okay. Now there's a lot of important past history here that you know that is being asked here. So this um right, this previous biopsy and surgery, right? So what are we trying to rule out here?
So by asking previous surgeries and biopsies, like these are risk factor for to give an inclination that it could be a bone sarcoma. Like radiation per se is a risk factor for sarcoma. Then previous biopsy, maybe some benign pathology of the bone may lead to sarcoma in the future. And also bone infarction and all those history is important because they are risk factors.
Yeah. So basically, when we ask previous biopsy and surgery, number one, we have to rule out a lot of these patients that come to our OPDs, right? They might have taken a prior biopsy, which is a big issue because if the biopsy is not taken with proper precautions, it can cause compartment contamination. So we are ruling out whether this particular suspected malignancy has previously been biopsied or underwent some sort of surgery. Because improper surgeries, improper biopsies can alter the management by contaminating the compartments, so that we're ruling out. Then like you mentioned, previous predisposing conditions, right? So a lot of these sarcomas, especially osteosarcoma, can occur in prior benign conditions like Paget's disease, osteochondromatosis, enchondromatosis, fibrous dysplasia, chronic osteomyelitis. So all these conditions you can have a secondary osteosarcoma developing from that. Although in this particular young patient we might not, it'll point more towards a primary one rather than secondary, right? So you had mentioned radiation also being can lead to osteosarcoma, right? Can you tell me what the Cahan's criteria is?
Yeah, the Cahan's criteria for secondary sarcoma, radiation-induced sarcoma, like the rim of the tumor should be in the previous irradiated field, and it should be biopsy proven, and it should be different from the primary histopathology, and there should be a latency period of around uh, 2 to 3 years, latency period of around 4 to 5 years,
Yeah,
and
you're right.
previously bone where the sarcoma is originating should have been previously normal.
Yeah. So that tissue should be normal, or by that we mean genetically or metabolically normal prior to receiving RT, right? So you're right. So you mentioned those 4 points are very important. A lot of the old timers, they tend to ask this question. Cahan's criteria for a secondary lesion
Mm.
arising from the irradiated site, right? So the risk is around 6.5 percentage uh, after 10 years of developing a secondary osteosarcoma. So this is, mainly in context of osteosarcoma. Um, okay. So moving on, we also need to remember. Okay, can we go to the next slide, please?
Yes, sir.
Yeah. So the menstrual and obstetric history, right? What is our primary concern here? Especially in this particular patient, her age is 19 years. What is our primary concern here?
The main concern is are with the fertility issues later on and family. If she plans to have a family, that are the only major concern.
Yeah, so fertility counseling is something, we need to know the proper menstrual and obstetric history, because fertility counseling is something that we will do down the line if we confirm it to be a sarcoma, right? Um, in a female patient, what are the, fertility preservation techniques that you know of? Can you name three?
Hmm. Like uh, ovary transposition can be one.
Okay, that's good.
Ovarian transposition can be one.
We usually
Then
use it in which
ovarian
context?
when you have to give abdominal RT,
Okay, good.
and then you can also go for oocyte preservation or embryo preservation,
Okay.
and Like there's gonadal shielding also, which I've heard of.
Yeah. Okay.
And yeah,
So yeah, but please
yeah.
go ahead.
No, it's this oocyte cryopreservation, embryo cryopreservation, ovary transposition, and
Yeah, I'll take all the answers you have given. To that, I'd also like to add ovarian tissue preservation. Okay, so
in tissue.
most commonly we do oocyte preservation. Right, in the context of RT, you can do a transposition of the ovaries. You can also shield the ovaries if the it comes in the radiated field. And although not as commonly done, you can remove the tissue, ovarian tissue, and preserve it as well. That is another option, although not commonly done. Another technique that has been tried is to give concurrent GnRH agonists with the chemotherapy. That is seen to alter the blood flow, decrease the blood flow to the ovaries, prevent chemotherapy from reaching the ovaries and causing, infertility. So concurrent GnRH agonists, it has mainly been done not in this context, but in the context of breast cancer. But if they ask you what are the oocyte, like the fertility preservation techniques, you can mention all these. Okay. Now, can we move to the next slide?
Yes, boss. Personal history.
The next one, please.
Okay.
So what is the importance of family history here?
Many bone sarcomas, they have a familial predisposition. Like, for example, Leaf-Ramoni syndrome will have osteosarcoma, hereditary retinoblastoma, then Rosemond-Thompson syndrome, then McCune-Albright syndrome. There are many to name. I'll just learn a few.
Yeah, I mean that's good enough. So you should be ready with a few syndromes that commonly lead to, sarcoma. So you mentioned most of them. This Leaf-Ramani syndrome. Can you name four malignancies seen associated with Leaf-Ramani syndrome?
Bone sarcomas first, then leukemia
Yeah.
and uh, lymphoma, leukemia, GI malignancies. It's like subla syndrome. I'm not able to remember right now
Yeah,
what is subla.
that's okay. This is like a bouncer question, not really related to topic, but yeah, you can just mention breast cancer. You can mention
Yeah.
adrenal tumors, right? You can mention leukemia, like you said, bone tumors, brain malignancies like high-grade astrocytoma or glioblastoma, to a lesser degree medulloblastoma, and also choroid plexus tumors. So I mean, those are the tumors commonly seen there. Okay, so now we have we have, can you go to the summary, please?
Yeah.
Yeah. So, you have right thigh pain since 3 months, progressive swelling in the right thigh since 2 months, and difficulty in walking since 1 month, right? So, based on this, what sort of DD would you like to give?
Since she is a young female and has a short history, so my first differential will be some suspected musculoskeletal malignant neoplasm.
Okay, good. Can you lean towards, skeletal or, muscular or soft tissue based on the history that we have given?
Yeah, since she presented with pain and pain appeared before the swelling came, so it is more like, so I'll keep the differential in terms of sarcoma. The bone sarcomas I'll keep above, then the soft tissue sarcoma I'll keep later for the second DD.
Yeah. So it looks to be like a malignant bone tumor rather than a malignant soft tissue neoplasm, right?
Yes,
Based on
boss.
the history. So, I mean, though, in this setting, so I like to tell everyone else. So, in this setting with this symptomatology, this is what you should say as the DD. Okay, this is what you commonly get these symptoms. So, don't go and make some exuberant, DD that you think will, flatter the examiner, because keep it simple. Stick to these two DDs that Dr. Raja mentioned. Uh, right. So, just want to ask you, sometimes the examiners tend to push you regarding this. Malignant soft tissue neoplasms of the extremities. What are some commonly seen soft tissue sarcomas of the extremities?
So most commonly seen in a young female will be alveolar soft part sarcoma,
Good.
usually seen in the thigh. Then liposarcoma,
Okay. Which type?
lipo,
We had discussed it earlier.
well differentiate, myxoid, sorry,
Mixoid.
myxoid,
Yeah, mixoid.
myxoid. and then synovial sarcoma,
Good.
and clear cell sarcoma.
Yeah, good. I think that's good enough. So myxoid liposarcoma, like you mentioned, synovial sarcoma, alveolar soft part sarcoma, clear cell sarcoma, and also you can get undifferentiated pleomorphic sarcoma. So all these are commonly seen in the extremities. When it comes to a young adult, you're right. Alveolar soft part sarcoma is the one of the DDs that you look at. Although it is rare, but it is more commonly seen in young, and not just young, in females as well. Okay, so although that is our second DD, malignant soft tissue neoplasm, these are the common ones that you can see in extremities. They can ask you this question. Okay, so you need to be prepared with the common ones seen there. Okay, now let's get into. Can you tell me based on age, right? So I want you to define that. What are the bone tumors? So our first DD is a malignant bone tumor. So what are the bone tumors you can get in less than 20 years, 20 to 40 years, and greater than 40 years?
So in less than 20 years, the bone tumors which will be common will be osteosarcoma, will be Ewing sarcoma, will be lymphoma, and can also be rhabdomyosarcoma, alveolar type of rhabdomyosarcoma.
Good,
In 20 to 40 years, osteosarcoma again can occur, and giant cell tumor of the bone can also occur, and lymphoma.
good.
And above 40 years, it will be more like the metastasis from any primary site, for example, breast or lung, and can be lymphoma also. And since osteo has a biomotor distribution in above 40, also osteosarcoma can also be a possibility. Myeloma can also be one possibility.
Okay. Can you name another bone tumor involving the cartilage?
Chondrosarcoma
Yeah.
above 40.
Yeah. So I think I won't repeat that again. You've perfectly described, uh, all the tumors less than 20 years, osteo, Ewing's, lymphoma, RMS. You also mentioned alveolar. 20 to 40 is osteosarcoma once again, lymphoma, your giant cell tumor. Then greater than 40 is chondrosarcoma. You can have Mets. You can have lymphoma once again, soft tissue sarcoma. You can also get, myeloma as well, right? So you need to know the DDs based on age criteria. Okay. So that is also something that they very commonly ask in these exams. Um, right. So now just getting into, these are, I would like to call it the scratching questions. As in, they're not really related, but I've seen examiners ask this in practical exams. Okay. So can you just tell me, just for completion's sake, um, so how do you differentiate with lymphoma?
Based on clinical history,
Yeah, based on our clinical history.
we have lymphoma. The patient will be middle-aged, second to third decade maybe, and will have constitutional symptoms.
And we'll have swellings elsewhere, right? Suprainfradefumal. Yeah. Okay. So we mentioned that greater than 40 years DD was chondrosarcoma, right?
Yeah.
So can you mention the types of chondrosarcoma? This is a very tough question. This is not commonly treated malignancy. The types of chondrosarcoma.
Uh, I remember the WHO criteria in the chondrogenic tumor. There was mesenchymal chondrosarcoma,
Good.
undifferentiated chondrosarcoma, and based on grade, I don't know, it can be
Yeah.
grade 1, grade 2.
Yeah. So I mean, you have got an idea. This conventional first of all. That's divided into grade 1, grade 2, and grade 3. Okay. The treatment there is it is chemo radio resistant, so we do treat by surgery only. Then there's something called this conventional can de-differentiate into a more aggressive variant that is called de-differentiated chondrosarcoma that behaves like osteosarcoma. Okay, so there you give treatment of osteosarcoma actually in de-differentiated chondrosarcoma, unlike conventional where you treat by surgery only. Then you have mesenchymal chondrosarcoma, like you mentioned, and mesenchymal is interesting because it is treated with Ewing's protocol. Okay, having mesenchymal chondrosarcoma. Then you get clear cell chondrosarcoma that is treated by surgery only. That is also a low grade tumor. So conventional, dedifferentiated, mesenchymal, and clear cell. Okay. So those are the four main types that you see. Most common is conventional. Just remember, dedifferentiated is treated like osteosarcoma, mesenchymal is treated like Ewing sarcoma. Okay. So this giant cell tumor, right, that we mentioned, or DD, occurs between 20 to 40 years. What is the treatment there?
Uh, you do curettage, and then you reconstructed by applying the bone cement
Yeah,
and
good.
steroid, intralesional steroid chemotherapy.
Yeah, you're right. So intralesional curettage, and you most commonly, the adjuvant that you apply is bone cement. Okay. What is the role of denosumab in GCTs?
No idea, boss.
Okay. So, I mean, don't mention denosumab unless asked. It is not used in all cases. It is used if the tumor is primarily inoperable. Okay. So, if
Okay.
you're not able to operate, you can decrease the size of the tumor. You can debulk the tumor by giving denosumab. That is usually given at 120 milligram, day one, 8, 15. Then it is given every monthly. Okay, so initially loading dose of day 1, 8, 15, 120 milligram subcutaneous, and then monthly. Okay, and then you give that for few cycles, and then you reevaluate to see if it is surgery is possible.
It is
Okay,
only for ACT. It's just
uh,
Tinsumab.
yeah. So for inoperable tumors, right? That we're not like you said intralesional curettage, but if the lesion is very extensive, or for example, it's involving the sacrum, multiple nerves are involved there, we might think of debulking the tumor a little bit. Okay.
Okay.
Okay, now so we have, I think we have discussed most of the important questions in history. Let us move on to the examination part of it.
Yes. So I'll start with the general physical examination. Patient was examined after consent. She was conscious and oriented. Performance score ECOG of 2. There was no pallor icterus or pedal edema. There was no lymphadenopathy, no swelling elsewhere. Vitals were normal. And then her height was 159 centimeter, weight of 57 kgs with a BSA of 1.58 per meter square.
Okay, good.
Should I move? Oh,
Yeah, please continue. You can finish off the entire examination.
yeah. So local examination, patient was examined in a well-lit room with a female attendant by the side. She was examined in supine position, hip was externally rotated and the knee was flexed. Inspection, there was ill-defined swelling noted in the lower and middle third of the right thigh and it had a irregular surface. There was no scars, venous, dilated veins over the swelling. There was no muscle wasting or foot drop. There was no swelling of the knee joint, and there was no swelling noted elsewhere in the thigh. Now, from after inspection, palpation. On palpation, there was local rise in temperature, and but there was no tenderness. Measurements, swelling was around 10 to 8 centimeter, involving middle and lower thigh, which had irregular surface. The margins were ill-defined and it was firm in consistency. The superior margin of the lesion was 12 centimeters above the knee joint. Inferior margin was 3 centimeters above the knee joint. The swelling was immobile, it was fixed, and it was continuous with the underlying bone. There was no pulsation which was felt over the swelling. There was no knee joint effusion or deformity, and the patellar tap test was negative. Coming on to the measurements, so I started with the initial measurement of the thigh. So thigh length of the right side was 41 centimeter, left side was 42 centimeter. Then total limb length was measured, which was 88 centimeter on the right side, 88 centimeter on the left side. Then coming to the lesion in the right side, the mid thigh girth, the lesion measured around 54 centimeter, and in the lower thigh, the girth was around 48 centimeter. In the left side, the mid thigh girth was 46 centimeter and lower thigh girth was 42 centimeter. And the maximum circumference of the lesion was 65 centimeter. Movements, knee flexion was restricted due to pain, but extension was full possible, but just mild painful. Hip movements, internal rotation was the most painful. Movement of contralateral hip and knee were full and were painless. Neurovascular examination, the power was adequate in all the limb. Sensations were normal. DTR, deep tendon reflexes were normal. Peripheral pulses were normal. And in systemic examination, there was nothing specific. So now to summarize, she's a 19 years old girl who presented with right thigh pain since 3 months and swelling since last 2 months, which was progressive. There was difficulty in walking since 1 month, and on examination, she had a large swelling which was arising from the distal thigh and which is continuous with the underlying bone.
Okay. So before we go into the DDs and further on, I'd just like to, just point out certain things in the examination. Yeah. You can go to the next slide. Yeah. So when you look at inspection, right, you need to look at where the lesion is, arising from. Okay. Uh, so sometimes, if in extensive lesions, you cannot say whether it's arising from the epiphysis, metaphysis, or diaphysis. But certain times you are able to make out where the epicenter is located at. So there they can ask you regarding the tumors that arise from epiphysis, diaphysis, and metaphysis. So can you just say that if possible?
So tumor which arise from the epiphysis are giant cell tumor and chondroblastoma.
Good.
Tumor arising from the metaphysis are osteosarcoma
Good.
and osteochondroma, chondrosarcoma, and from the diaphysis, uh, are Ewing sarcoma, myeloma, aneurysmal bone cyst.
Okay. Yeah. So you're almost right. Like you rightly pointed, epiphysis is GCT, chondroblastoma. Metaphysis is osteosarcoma, osteochondroma, and chondroma. Diaphysis is Ewing sarcoma, myeloma, and osteoma. Okay. Aneurysmal bone cyst is from the metaphysis. So you're right. So that's how you say it. You need to be aware of the tumors, bone tumors that arise from each part of the bone. Okay. And if possible, on if on examination if you're able to say, you can also mention that there's no issue there, but sometimes with extensive lesions it's difficult to make out. Okay. I'll just quickly go through some things before getting to the main part of the discussion, that is the workup and treatment. So scars, obviously we're looking for previous biopsies that have been done, because like I said, compartment contamination. Where do we see these dilated veins in context of bone tumors, bones, like where can we see dilated veins?
Uh, in context of bone tumor, like in a variant of osteosarcoma, which is telangiectatic, can have
Yeah, you're right. Good.
dilated veins.
Yeah. So yeah. So in the context of, like, we are malignant bone tumors, that's what we are thinking, right, in the DD. So one of the variants, telangiectatic osteogenic sarcoma, can have dilated veins. Also, you can get it out of this context. Aneurysmal bone cyst can also present with dilated veins, right? And then we've also elucidated muscle wasting, foot drop, whether it's present, neurovascular involvement can present with those features. And no selling elsewhere, we are looking at elsewhere in the thigh, we're looking at skip mets once again. Okay, can we move on to palpation, please?
Yes.
Okay, now local rise in temperature. What are the features associated with local rise in temperature? Like what all scenarios will you get it in?
Local rise of temperature points towards that there is an inflammatory cascade which is happening. For example, in case of any infection or abscess, or in case of trauma, or in case of yeah.
Yeah. So it can be due to the so I'll just tell you the points. It can be due to the tumor itself, right? These tumors are highly vascular, so that can also increase the temperature. Okay. So you can get it in a normal case of osteosarcoma that can have increased temperature. Then of course, if there's fracture, associated fracture can increase the temperature of the local site. And in case of infection, associated infection with the bone tumor. And tenderness, obviously, it's with fracture or associated infection, right? Um, uh, and you have mentioned here, this is very important to elucidate in your palpation. Okay, just to point it out, uh, you have mentioned here that it is continuous with the underlying bone. So swelling is immobile, fixed, and continuous with the underlying bone. So if you're able to elucidate that, that is very important. That will further you know uh, make your differential diagnosis concrete. Okay, so continuity with underlying bone puts your DD at the end of your examination more in favor of bone tumor. Not more in favor, but almost, you can say, with certainty, right? Um, so that is very important to write down. All these points here are very important to write down. Okay. So, right. So patellar tap test, we are looking at joint effusions. Yeah. Can we move on, please?
Yes.
So we looked at joint involvement. We look at you know whether there's foot drop, whether there's muscle wasting in inspection palpation. All these point towards advanced disease, and that can be. We'll talk about it later. It can affect the management, especially the surgical management, right? Whether we're going for salvage, limb salvage surgery or amputation. So all these are clues that we look at in the examination. Okay. Um, okay, right. Now moving on. You've mentioned the movements and the measurements. Can you tell me how do you measure the thigh length?
Thigh length is measured from the anterior superior iliac spine to the top of the patella,
And
or
the
from the midpoint of the inguinal ligament, midpoint of the inguinal ligament to the top of the patella.
and lower limb, the entire lower limb, where do you measure it from?
From the midpoint of the inguinal ligament to the medial malleolus is the total limb length.
Okay, yeah. So you're right. So that's how you measure that. And can we move to the next slide?
Yes.
So once again, okay, movement, then next one. So in movement, you look at range of motion, you look at whether the normal movement. So you need to know the normal movements for the common joints. And then you need to look at whether range of motion is restricted, whether it's associated with pain, right? Neurovascular examination, once again, if there is advanced disease, your neurovascular bundle is involved. There also, this can be affected. And that is important, once again, in the context of surgery, uh, whether we go for limb salvage versus amputation. So if you can, my message to everyone is, when it comes to examination, write it down just like this. Don't miss a single point. When you're getting a sarcoma of the extremity or a bone tumor sarcoma, write all these points down. All of them are very important. If you write it down and you say it as such, the examiner won't ask you a lot of questions. They won't poke around too much. Okay. So, unless you create problems for yourself by missing out on certain points. So, inspection, palpation, movements, measurements, and neurovascular examination, all five components should come in your examination. Okay. Yeah, I just want to point out, what all those specific points mean and why it is important to write all five of these subheadings. Okay, please move on to the next slide.
So this is the summary of the case after history and examination.
Yeah, so what will your differentials be here now after your examination?
So it will be in a young female, 19 years old, after history and examination. My first differential would be some suspected musculoskeletal neoplasm, suspected bone tumor, malignant bone tumor.
Yeah. Okay. So, right. So now we have established that the tumor is arising from the bone. It is in continuity with the bone as well, right? And with the history earlier that we had, of pain occurring before swelling. So combining everything together, we can say it's a malignant bone tumor. So what are the features in favor of osteosarcoma, or what are the features in favor of Evans? Which one will you go towards?
The age favors osteosarcoma, and osteosarcoma has more propensity towards the appendicular skeleton, Ewing's more towards the axial skeleton. So this is one thing I'm thinking that it could be more osteosarcoma. There is no constitutional symptoms, which makes me go towards osteosarcoma. And yeah, just two things.
Yeah, so you're right. So, like you said, DD is malignant bone tumor, right? Right, with the current history and examination, bone because, like we said, pain before swelling, circumficial growth, and fixity and arising from the bone that has been established in examination. Then within this bone tumor, what are the points you look at? Put it in favor of osteosarcoma. There is no constitutional symptoms. Although not all Evings will have constitutional, but yeah, that is one of the points. Then age. So Evings will be usually, before the less than age of 20 or below, whereas anything above the age of 20 and above, 20 to 30, it's more likely osteo than Evings. Then, of course, the location of the tumor, if you're able to elucidate in the examination, although in this case it was more extensive, right? So, Ewing sarcoma is usually, it is most common in the femur, tibia, and fibula, but it is more likely to occur in the pelvis and the vertebral bones as well than osteosarcoma. Okay, so both osteosarcoma and Ewing sarcoma, most common site is the around the knee joint, distal femur, proximal tibia, distal femur, proximal tibia, right? Both osteogenic sarcoma and Ewing sarcoma. But Ewing sarcoma has a higher propensity for pelvic mets, for vertebral mets. So that is another point that could, draw the line towards osteo versus Ewing's. So just remember all these points, how to differentiate after history and examination between bone and soft tissue, and how to differentiate between the likely candidates for bone malignancy, that is osteosarcoma and Ewing sarcoma, especially if it's a young patient. So that is something that you need to know. The examiner will ask you what are the points in favor of, or be ready with your DDs, be ready with your points in favor of. Okay, good. Excuse me. Now let's move on to the next thing. How will you, you have thought about osteosarcoma, right, of the bone, right, of the femur, right? So, how will you work up this patient? Please tell me your, just summarize quickly your workup for diagnosis first. Then we'll move on to the next workups after discussing that. So, workup for diagnosis, what all will you do?
In diagnosis, I'll include first about the workup for the general well-being, complete blood count, and all those things, LFT and KFT. And then for diagnosis, I'll go with the X-ray of the local area in two planes, AP and lateral, first of all. And then I will order a biopsy, core needle biopsy.
Okay. Before the biopsy, would you like to do something else?
Before the biopsy, before the biopsy, I'll go for a local imaging like MRI of the affected area.
Yeah. So you're right. So workup for diagnosis, you start off with an X-ray of the local part. In this case, it is the right femur with the adjoining joints. Okay. So like X-ray of the local part, right femur with, the hip joint and the knee joint, right? We do that. Then we do an MRI of the same thing, of the lesion, of the entire bone, and the adjoining joint should be taken, contrast enhanced MRI with gadolinium. And then after that, we go for the biopsy. So now, can we go to the next slide, please?
You have the X-ray now.
Yeah. So can you describe this X-ray for us?
Yeah, it's a radiograph of the knee joint in two views, anterior-posterior and the lateral view. It is a radiograph of a mature skeleton, and there is a lesion which is predominantly in the metaphysis, extending into the diaphysis and also the epiphysis, uh, but it is not involving the joint. The lesion is radiolucent and also radiodense with sclerotic and lytic components. It is more of a sclerotic bone forming and also lytic. It is a like mixed lesion, and the lesion is also there is no cortical breach, there is no fracture, and there is a soft tissue swelling in and around the lesion in the thigh, and there are a lot of perpendicular lines which are speculated lesions which are arising from the periosteum. Looks like some aggressive periosteal reaction.
Okay. Okay, yeah. So I think you have mentioned most of the points. Now, for this sake of everyone, I'll just re-summarize those points in order. Okay. So this will definitely be asked. Bone tumor, you're going to get an X-ray. So first of all, I'd like to set this is an X-ray of the knee joint, right? Where you can see the distal femur. Now, this is not an ideal X-ray, right? Ideally, it should be the entire bone with the adjoining joints, right? So if you get this X-ray, what you can say is, especially in osteosarcoma, you first describe it's an apilateral view of X-ray of the. Ideally, it should be the entire right femur with the hip and adjoining hip and knee joints. So here you can see a lytic sclerotic mixed lesion arising from the predominantly from the metaphysis and extending to adjoining areas. Then you should mention the zone of transition. So there's a wide zone of transition between the normal and diseased bone. Benign lesions will have a narrow zone of transition, whereas malignant lesions will have a wide zone of transition between the normal and diseased bone. Okay. It involves the cortex. It also involves the medulla. You can clearly see that. Then there is a periosteal reaction. Okay. So here in this particular X-ray, you can see features suggesting of Codman's triangle, and you can also see features suggesting of sunburst pattern as well. Okay. Then you have to describe whether there's a soft tissue lesion, if that is there. Then, of course, since you're taking extra of entire bone, ideally, you should look for skip metastasis, so no skip mets. And also, at the end, you should also mention no fractures. Okay. And you can also see whether there's joint involvement or not. You can roughly say. So all these features that I mentioned, go back and watch the recorded video. All these features that I mentioned, you should be able to say for your practical exam. If you say this, the exam will automatically say very good. Okay, that is what they're looking for. You have already given the correct answer. I'm just telling you what to say so that you can make it perfect. Okay. So these are the features that you will look at. Now, they will ask you here, what is Codman's triangle?
Codman's Codman's triangle is since the bone is in the it is an intramedullary lesion. So when the lesion is expanding, it is osteoid forming, and two for and it is osteoid forming. It is expanding. So the periosteum reacts and it uplifts, and there is a new bone formation, which is known as the Codman's triangle.
Yeah, so basically elevation of the periosteum with only ossification of the edges leads to a triangle-like formation, and that is Codman's triangle. It's a form of periosteal reaction. What is the sunburst pattern?
Sunburst pattern are these perpendicular spicules which are seen in the periosteum, which denotes some osteoid formation
Yeah,
because of the periosteal reaction.
so it's ossification that is perpendicular to the bone, and it is seen as linear strands that are emitting from the bone, and the ossification occurs along the vascular channels or blood vessels. Okay. So
Okay.
that point also you can add. It's perpendicular ossified bone along the vascular channels or blood vessels. Okay. So next, so Skorman triangle sunburst appearance can be seen in predominantly described in osteosarcoma. It can also be seen in Ewing sarcoma. It can also be seen in certain benign conditions like osteomyelitis. It can sometimes be seen in giant cell tumors that are slightly more aggressive. Right. What is this onion skin reaction?
It is also a periosteal reaction which is seen in Ewing sarcoma. There is a uh, there is zone of formation of bone and no formation, which is because Ewing's periosteal reaction is not aggressive as like osteosarcoma.
Yeah. So basically, it is a multi-layered periosteal reaction, right? So there are multiple concentric parallel layers of newborn formation, denoting, the variable growth rates that are seen in the tumor. So there are multiple layers of periosteal reaction, that is onion skin appearance, classically described in Ewing sarcoma, although it can be seen in other like osteosarcoma as well. Like you said, Ewing sarcoma is where it's classically described, but also other aggressive sarcomas, bone sarcomas, it can also be seen like osteosarcoma. So those are the three, named lesions that they tend to look at. Then you also have some other lesion like soap bubble lesion that can be seen in your giant cell tumor, etc. So that's regarding the X-rays. Can you tell me one X-ray feature of chondrosarcoma? This just I'm once again being slightly rough here. These are not questions that are commonly asked, but if you answer everything, they can ask. Chondrosarcoma, what do you see that we don't see in osteosarcoma?
No idea about.
So you'll see something called endosteal scalloping. Okay. Sometimes in X-ray, you can also appreciate it better in CT scan, and there'll be something called popcorn or ring calcification. So that imaging can differentiate, the tumor from osteosarcoma. So we have done our first for workup for diagnosis. First, we've done X-ray of the local part, uh, entire bone with adjoining joints. Now MRI, right? So what are the things that you'll see in your MRI that what useful information can you derive from your MRI?
So MRI has a excellent contrast of the soft tissue. So it will help me to delineate the extent of the tumor better and also help in the operative planning later on.
Yeah.
It will help to evaluate whether there is involvement of any major vascular pedicle or neurovascular bundle. It will help to also evaluate the bone marrow, and it will also help to know the skip metastasis.
Yeah, you mentioned the important points. So I'll just summarize it again for everyone else. So when you do MRI, this is a very commonly asked question, by the way. So MRI, you do contrast enhance of the entire bone with adjoining joints. So like he said, planning for biopsy and surgery. Then you can denote the soft tissue component. The extraosseous tumor extension can be delineated. Bone marrow involvement, joint involvement, neurovascular bundle involvement, skip mets can be seen, and also peritumoral edema can be delineated. So when you're excising the tumor, doing limb salvage surgery especially, you can delineate the plane of resection that you're planning. Okay, so peritoneal edema can also be seen. So that is our MRI, what all information we can grab from our MRI. Okay. Now, next we do your, blood workup and viral markers, and then you go for your biopsy. So what sort of biopsy would you prefer here?
I'll prefer core needle biopsy.
Yeah, why not open biopsy?
Uh, Open biopsy will lead to tumor seeding,
Okay.
and it can also lead to contamination, and there will be involvement of the major other compartments also, which
Yeah.
will lead to, because our aim is lymph salvage surgery, and it may lead to amputation. So there is
Yeah.
no point of doing the
Yeah, you're
open.
right. So we always go for a core biopsy, right? So what are some of the rules you should follow when you're doing a core biopsy of this bone lesion?
So the biopsy, the core, in terms of core biopsy, the biopsy should be done by the same treating surgeon who will operate who will operate it later on, and the incision of the biopsy should be perpendicular to the long axis of the bone, and incision should be in line with the future surgical resection, and there should be no contamination of the compartment, and there should be no excising of the muscle, no splitting of the muscle, and there should be no placement of drain. We have to avoid placing the drain at the surgical site, and the surgeon had to make sure that whatever surgical scar is there, it should be easily removed at the time of surgery, and if possible, he should ink that area also.
Yeah. So you have perfectly said what all we need to be cautious about while doing biopsy. It should be done by the same surgeon. It should be from a soft tissue component. It should be a single incision. You should avoid the use of a drain. It should be a perpendicular approach, and it should be along the long axis of the bone. And it should be perpendicular to the long axis of the bone. It should not cross or invade muscle planes. And you should ink the site ideally to include in the resection during surgery, right? So all these points should be important. So that is why when you get an external biopsy done, usually they do not follow the rules if it's done by someone who's not trained in oncological surgeries. So that's why you should always be careful. Biopsy should be done with these rules in mind. This will definitely be asked in a bone tumor case. Okay, so now we have done our workup for diagnosis, right? Now let's move on to our workup for staging. What all will we do? We are thinking more in terms of an osteosarcoma, right? So what all will we do here?
So I have done a MRI of the local area already.
Yeah. So diagnosis is
Now
done.
Yeah. Now to complete the staging, I'll go for a HRCT of the thorax to evaluate for any lung metastasis. I'll also order technetium-99 bone scan to look for bone metastasis.
Yeah. Yeah. So very good. So those are the two, metastatic workup modalities we'll do, a HRCT thorax and a technetium-99 bone scan to rule out bone mets and skip mets in the same bone, right? So this HRCT, this is once again a slightly, I'm trying to scratch here. What is the difference between, why do we do HRCT rather than contrast enhance?
Because I need to see because this osteosarcoma has more propensity towards the parenchymal lung parenchyma rather than the mediastinum. So I need to see the lung parenchyma more clearly than
Yeah,
the
so
mediastinum. So
the main reason is that if once you've established osteosarcoma, right, it leads to osteoid formation. So we need not, we're not looking for any contrast enhancement or any feature like that. So HRCT can easily pick up that, osteoid formation. So we need not do contrast. We not give contrast, unlike other, tumors. Okay. So just to complete all the questions that can be asked, can you tell me the Eniking staging for osteosarcoma?
So Anakin staging for osteosarcoma is based on the T size, the grade, and the metastasis. So for stage one, it is 1A and 1B, and stage one is always low grade. In stage one is always low grade divided into 1A and 1B. In 1A, it is T1, which is intracompartmental. In 1B, it is T2, which is extracompartmental. In stage two, it is always high grade. T1 intra-compartmental will be 2A, 2B will be T2 extra-compartmental, and in stage 3, any T or any size, and always high grade.
and involvement of the regional nodes or distant mets, right? Stage 3.
Yeah,
Yeah.
stay.
So that yeah, so
Yes,
that is
yes.
anything staging, like you rightly mentioned. You should also study the AGCC staging. Okay, we won't mention that here, but just look up the AGCC staging in osteosarcoma. There it is divided into stage 1, 2, 3, and 4 as well, right? Based on the grade, based on the T size, that cutoff for T1 versus T2 is 8 centimeter, based on the lymph node mets, based on the distant mets. So just
And
study AGCC as well. They can ask you that. Now, before we complete our workup for diagnosis and staging, histopathology, what will you see in an osteosarcoma case?
mm, in osteosarcoma and histopathology, there will be obviously those malignant processes, high NC ratio, chromatin condensation. But I don't know anything specific
Yeah,
microscopy.
so when you say just very simple, you'll see spindle-shaped tumor cells that are secreting osteoid. Okay, so that is a characterizing feature. There should be secretion of osteoid that is there. That defines osteosarcoma. What are some of the IHC markers that are specific for osteosarcoma?
So in IHC, osteosarcomas are osteonactin and osteocalcin positive. Uh, SAT-B2, although not very specific, but gives a hint. SAT-B2 positivity will be there.
Yeah, so
And
those three that you mentioned, those are the specific ones. You're right. Just out of, for fun, where else do you see SAT-B2 positivity?
in colorectal malignancy.
Yeah, you're right. So colorectal also you see SAT-B2. Completely unrelated site, but you tend to see that there as well. Can you classify osteosarcoma based on histology?
Osteosarcoma based on histology. Yeah. So low grade and then high grade. High grade is conventional osteosarcoma, not otherwise specified. Then we have uh, telangiectatic and small cell variants in high grade. Then in low grade, uh, in low grade surface osteosarcoma, we have parosteal osteosarcoma, which is low grade, then periosteal osteosarcoma, which is intermediate grade, and then high grade surface osteosarcoma.
Yeah, so you're right. So when you answer this question, I'll just organize it a little bit. So you can divide into central as well as surface. Okay. So central you have low grade, which common time serious fibrous dysplasia like osteosarcoma, which is central. Then central you have most common one is osteosarcoma, not otherwise specified, right? Which is high grade. So within that, most common one seen in 80% of cases is conventional osteosarcoma. Conventional can be most commonly osteoblastic, followed by chondroblastic, followed by fibroblastic, followed by mixed. Okay. And then the other types of high grade intramedullary osteoblastoma is telangiectatic and small cell. Okay. Then, so that is central, divided into low grade and high grade. And we spoke about the subtypes. Surface, like you correctly mentioned, is low grade, which is parosteal, intermediate grade, which is periosteal, and high grade surface osteosarcoma. You can also have secondary osteosarcoma or extraskeletal osteosarcoma. That's the based on the histology and location, right? Excuse me. Yeah. So now that we have done that, what is a workup for treatment?
So for workup for treatment, uh, I'll since I have to plan multi-agent chemotherapy, so I'll go for uh, uh, echocardiography. I'll go for ECG. Since I have to also administer cisplatin, if feasible, I'll get a DTPA scan. I'll get a pure tone audiometry. And since she's a young female, I'll also discuss about the fertility preservation.
Very good.
Um yeah, uh,
Yeah, so I think you've mentioned most of it. So, for platinum, we'll do a create clearance, if possible, a DTPA, we'll do a pure tone audiometry, right? And for anthracyclines, we'll do an echocardiogram along with an ECG. Fertility preservation, once again, it's good that you mentioned it, very important. Always mention it in a young patient, right? And then, okay, now we have done the workup, right? Diagnosis. Just to summarize, diagnosis, we've done X-ray, MRI, true cut biopsy, core needle biopsy. Then for metastatic workup, we have done our HRCT thorax and bone scan. Then for we also done a workup for treatment. Now, how will you proceed in this case?
So I'll discuss this case in a multidisciplinary tumor board consisting of the pathologist, medical oncologist, orthopedic oncologist, and radiation oncologist.
Good.
Then after the MDT
What will be your
discussion,
basic treatment plan? Can you tell
uh,
me the exoskeleton of your basic treatment plan?
so it will be neoadjuvant multi-agent chemotherapy,
Okay. What is your
followed by
regimen that you will give?
so in our institutional practice, we usually go with uh, MAP regimen, methotrexate, adriamycin, and cisplatin. And then we after assessment we go for surgery and then adjuvant MAP. Neoadjuvant MAP, surgery, and then adjuvant MAP.
Okay. So neoadjuvant treatment, do we directly go for surgery? Before surgery, what can be done?
Before surgery, neoadjuvant chemotherapy was.
Yeah. So neoadjuvant chemotherapy, you'll reassess with imaging prior to surgery. Then you'll do your surgery. You'll prefer limb salvage surgery, right? Followed by adjuvant
Right.
chemotherapy. So, like you said,
Chemotherapy.
one thing I like to point out here is that in his institute he uses MAP regimen. A lot of Indian setups, especially in government setups where there aren't that many beds, people use IAP regimen as well. That because methotrexate, there are certain challenges. We'll get into all that. So say the regimen that you use in an institute. Okay. Because if your consultants are there, they'll back you up with that. Don't say something that's not used in your institute. Okay. So now let us. So since IAP is very commonly given, we'll get into high dose methotrexate. Don't worry, but IAP is very commonly given. So this IAP regimen, right? What is the evidence for that actually?
Yes.
Around the world, people give MAP, but why do we give IAP?
So for the IAP regimen, there is a study from Tata Memorial Hospital from India where they have compared that the non MTX regimen in the form of IAP has equal OS benefit as compared to the MAP regimen and equal EFS.
Yeah, so you're right. So there's a
So
OGS 12 study, which is a retrospective
OPS
study,
12.
which has shown that a non-methotrexate contained regimen can have equivalent survival benefit of around 60 percentage, right? Overall cure rate of around 60 percentage by omitting methotrexate. Now, can you describe here how to administer? So neoadjuvant will give IAP. In Indian setting, mostly we give IAP 2 to 3 cycles. Okay. So can you tell me how to administer this IAP regimen?
So to administer IAP regimen, since it is a very highly emetogenic drug, so I'll also have to tell the prescription of IAP.
Yeah, all the medication, pre-medications, chemotherapy, everything. Yeah.
Since it's a highly emetogenic chemotherapy, I'll start with injection aprepitant. I will start with tablet aprepitant, 125 mg on day one, followed by 80 mg on day 2 and day 3. I'll start with injection Dexa, 8 mg, plus H1 blocker, Rentac. Hello?
Yeah, go on.
Yeah, sorry. I will start with injection Dexa 8 mg and Rentac, one ampoule in 100 ml NS. I'll give it over 15 to 30 minutes. Then I'll start first of all with the doxorubicin, because since it is a vesicant, so I'll start with that. I'll give doxorubicin in the IAP regimen. It's 60 mg per meter square. Yeah, 60 mg per meter square. I can give it as a IV bolus, or can give it in 100 ml normal saline over 20 to 30 minutes.
Good.
Then after adriamycin, I'll again give 100 ml of IV flush, and then I'll give injection ifosfamide. I'll give ifosfamide 1.8 gram per meter square from day 1 to in IAP it's 1.3 gram per meter square from day 1 to day 3. I'll uh, give injection first of all I'll give mesna before administering injection ifosfamide. Mesna around 360 mg per meter square. I'll give 15 minutes before the administration of ifosfamide. Then I'll give, or I can miss the Masna and ifosfamide on the same bag and can give it also. I'll give it in 500 ml NS over 2 hours, ifosfamide. Then I will give injection cisplatin. Uh, I will ensure that there is a hydration of around 2 wax of NS, 500 ml, around 1 liter over 2 to 3 hours. Then I will give injection. I will see the urine output. Then I will give injection mannitol 20% over 30 minutes. Then I will administer NS with magnesium sulfate and KCl, and then I will administer injection cisplatin in 500 ml NS, 0.9% over 1 hour, and then in after completing cisplatin, I will again give injection NGSO4, injection KCl, and injection NS over 1 to 2 hours.
Yeah. So you've mentioned most of it. I'll just summarize it again very quickly. So IAP regimen, like you mentioned, you give your pre-medications, right? It's a highly emetogenic regimen. You're giving cisplatin. So you start off with ondansetron. You start off with Dexa. You start off with anti-H1 antagonist or PAN40, right? And you give that as a 15-minute infusion in 100 ml NS. You can mix all of that together. Then you give your NK1 antagonist, so either fosaprepitant 150 mg in 100 ml or 30 minutes, or you can give aprepitant 125 mg day 1, 80 mg day 2 and 3, like you mentioned. Then you'll give your, like you clearly mentioned, a vesicant. Strong vesicant is doxorubicin, so you give 60 milligram per meter square. You can give that as IV bolus or 100 ml over 15 minutes. Then you follow that up with ifosfamide. So ifosfamide is given at 1.3 grams per meter square, day 1 to day 3. Doxorubicin is day 1 only, ifosfamide day 1 to day 3. And along with that, you give mesna at 60% of that dose of ifosfamide, and you divide that mesna over at start of ifosfamide at 4 hours and at 8 hours, right? And then
Yes.
you give cisplatin. So cisplatin prehydration is given. That is 1 liter of NS over 2 to 3 hours, or divided into 2 pints. Then you give your mannitol, like you mentioned, 20%, 200 ml. And then you give cisplatin. So cisplatin dose in IAP is 100 milligram per meter square. Usually we divide it over 2 to 3 days. Okay. So usually we give it over 2 to 3 days. So you can give 50 milligram day 1, 50 milligram day 2. And right. So you give cisplatin over 1 hour, since it's a lower dose. And then you give post cisplatin hydration. So two pint NS once again. You can add potassium chloride, or you can also add magnesium sulfate ampules along with that post hydration. And then you give your post chemotherapy antiemetic prophylaxis. So there you can give Dexa. You can also add olanzapine, and you can also add PAN40, right? So Dexa 4 mg BD for 3 days, olanzapine 5 mg OD for 3 days, and PAN40 OD for 3 days. Okay, some people also add Emiset and omit olanzapine, depends on institute protocol. So that is how you give IAP regimen. You give 2 to 3 cycles of that, right? So now here I would like to talk about, like I said, any chemotherapy regimen, they can ask you specifically about the chemotherapy, right? So yeah, so ifosfamide, I'd like to ask you a couple of questions there. When we talk about ifosfamide, we need to know about the toxicities. So what is this ifosfamide-based CNS toxicity?
So ifosfamide-induced encephalopathy can occur, which happens due to the formation of a agent called as chloroacetaldehyde, which penetrates the brain and causes encephalopathy.
Yeah, good. You mentioned the agent also. So how do you so it causes CNS toxicity, right? So you can have confusion, you can have impaired sensorium, hallucinations, blurred visions, seizures as well. So how will you treat such a patient?
So if there is a ifosfamide-induced encephalopathy, then it is usually transient, and with supportive care in 2 to 3 days, it normalizes. But if I'm suspecting ifosfamide encephalopathy as a preventive measure, we can give methylene blue 50
Yeah.
mg and can also add injection thiamine.
Yeah, good. So so you can give it prophylactically in patients who have previous history of CNS toxicity, or if the patient develops CNS toxicity, you give 50 milligram methylene blue, and you give it every 8 hourly till the CNS toxicity stops. If the patient develops CNS toxicity, you can also give high dose steroids as well. Okay, so you're right there. Now, I also want to ask you, this why do we give this mesna?
Mesna to prevent hemorrhagic cystitis, like to wash out the acrolein. And
Yeah,
Mesna has a sulfur hydryl group, which the acrolein gets attached and it gets easily washed out in the urine, comes out from the body.
yeah. So if you develop a case of hemorrhagic cystitis, how will you manage it? Can you just tell me how?
Uh,
What are the steps? A few of the steps that you will do that come to your mind.
when a patient develops hemorrhagic cystitis, I'll ensure that there is adequate hydration. Uh, I'll keep giving Mesna because it is happening due to the acrolein metabolite, and I want the kidney should filter it out as soon as possible. And what else can we do?
Yeah, I'll just quickly
And
mention
medicine.
that. So hemorrhagic cystitis, once you get it, like you said, you need to put a two-way Foley's catheter, right? And you need to start saline hydration, okay, irrigation at a fast rate. So that's number one. Number two is you'll do a cystoscopy. You'll look for any clots. You'll evacuate those clots. If there's any bleeding pointers, you'll do fulguration. Okay. If there's still persistent hematuria, you use a three-way catheter and use saline. Okay. And once again, with the three-way catheter, if it's not working, you'll once again do cystoscopy, clot evacuation, and fulguration. Then, along with the irrigation, you can also add carboprost. You can add 1 to 2% alum. You can add silver nitrate. So that can also be added. Now, in severe cases, that is not even, despite three-way irrigation with addition of these substances, despite clot evacuation, despite fulguration, there you can do, you might have to do a bilateral percutaneous nephrostomy to divert. You might have to do a selective arterial embolization. You might have to do a cystotomy. In very severe cases, you might have to do a cystectomy, right? So those are the what you do, how you manage your hemorrhagic cystitis. They can ask you this. Uh, this suppose you're given this IAP regimen, the patient's sodium falls to 110. Why so?
Because of fluid overload, maybe first thing which I'll remember, which I'll think of. And next could be where this ifosfamide causes nephrogenic diabetes insipidus,
Good.
and I'm not sure.
Yeah,
Okay,
so
okay.
you're actually right there. So there are multiple causes in this regimen, right? That's why. So it can be due to dilutional hyponatremia. It can be due to SIADH, syndrome of inappropriate secretion of ADH, in due to ifosfamide. It can be due to cisplatin-induced nephrotoxicity can cause hyponatremia. So all these causes are there. What are some other chemotherapy agents that cause SIADH?
Vinca alkaloids.
Very good.
uh,
What
what
is the brother of ifosfamide?
Cyclophosphamide.
Yeah. So cyclophosphamide, ifosfamide, your Vinca alkaloids, especially vincristine, they cause SIDH. So you need to be aware of that. Right. Now moving on, something I want to ask you about anthracyclines. Anthracyclines cause, suppose we said we give it first because it causes extravasation. So in every chemotherapy regimen, you give the extravasation agents, the agents with high risk for extravasation first, right? So you get a case of anthracycline extravasation. How will you manage it? Can you tell me all the steps?
So for anthracycline extravasation, boss, no?
Yeah.
So step one will be I will stop the infusion immediately and I will not remove the cannula. Step two is I will identify the extravasatous agent, which is already anthracycline, you have told me. Step three will be I'll gently try to aspirate as much of the drug as possible from the cannula in situ without applying any manual compression over that. And then after aspirating all the drug, I'll remove the cannula, and then in step four, I'll try to uh, put a outline around the extra vasated site. And in step five, I will use specific measures. Like since it's anthracycline, I'll use a protocol of dilute and I'll use localize and neutralize. I'll use cold compression so that the drugs get localized and it neutralizes. And I will use dexazone in the opposite limb. at the dose of around 1000 mg per meter square on day 1, 1000 mg per meter square on day 2, and 500 mg per meter square on day 3. And I will also apply, I forgot, topical DMSO cream if
Yeah.
available.
So you have outlined all the steps. Just to summarize, they will ask regarding extravasation. It's a favorite question. You have mentioned all the points. I'll just mention them again for everyone's sake. So first of all, extravasation: identify the agent, stop the infusion, keep the cannula in place, aspirate as much as you gently can, mark the extravasated area, then apply. Look at whether it's a DNA binding or non-DNA binding. If it's DNA binding, then you need to localize and neutralize. Apply your cold compression 30 minutes, 4 times a day for 2 to 3 days. Then next thing you can do is up to apply DMSO. DMSO is a free radical scavenger. You apply, it's given at 99% concentration. You apply 4 drops per 10 centimeters square of surface area to twice the area that's extravasated. So the extravasated area and the area around that as well. And then another option that we don't commonly use is dexrazoxine. Like you mentioned, the dose 1000 milligram per meter square on day 1 and day 2, 500 milligram per meter square on day 3, right? So all those points need to be mentioned. You have mentioned them very well. That is the answer we are looking for when we ask that question in the exam. Okay, now moving on. Methotrexate, right? High dose methotrexate. Can you tell me some other indications where we give high dose methotrexate? So these are the questions regarding IAP regimen. You had mentioned the MAP regimen. So what are the indications where we give high dose methotrexate?
So high dose methotrexate is given in primary CNS lymphoma and in DLBCL, diffuse large B cell lymphoma, if the patient has a high CNS IPI,
Good,
and then we give in osteosarcoma, and then Burkitt's lymphoma.
good.
The uh, okay.
Yeah, I mean, that's that you have mentioned most of the important sites. So primary CNS lymphoma, osteosarcoma, you can give it in acute lymphoblastic leukemia as part of consolidation. CNS prophylaxis if CNS IPS score is high in case of high-grade lymphomas. Then, of course, in Burkitt's lymphoma, like you mentioned. And also, if you want to add an extra point as part of SMILE protocol, when you're treating
That's fine.
NKT cell lymphomas, right? So all these are high. So what is the dose of high-dose methotrexate? Like, what is the cutoff?
So if we are giving if more than 500 mg per meter square, then we label it as a high dose MTX
What are the
regimen.
precautions that you need to undertake prior to? What are the drug interactions and the precautions that you need to undertake before giving high dose methotrexate?
So first of all, I need to see that all the lab parameters, LFT, KFT, and CBC should be normal. There should not be any third spacing in the form of pleural effusion or ascites, because the drug can stay there and can cause toxicity. And I need to see the renal function test should be adequate. And interaction is with there are a lot of drugs we need to see before giving MTX, like NSAIDs, like proton pump inhibitors, like sulfonamides, and antibiotics, cephalosporins.
Penicillins mainly. Also cephalosporins, but yeah. So I'll just quickly, like you said, you mentioned all the precautions. So do your renal function test, possibly if needed a creat clearance, uh, right? Do your LFT evaluation because there's also hepatic metabolism. Exclude third space involvement. Then look at the serum albumin level because albumin binding is important. Low hypoalbuminemia can possibly increase the toxicity. Rule out drug-to-drug interaction. So aspirin, penicillins, some cephalosporins, NSAIDs, probenecid, all these drugs, right? Um, PPIs can also, interfere with, can increase the toxicity. If the patient is on prophylactic Septran, that should be avoided, right? Folic acid supplements should be stopped. So all these you need to look at prior to giving high dose methotrexate. Okay. Um, so here, how will you, with high dose methotrexate, what will you give?
Yeah, I will also go ensure leucovorin rescue later on.
What will your dose be?
For leucovorin rescue, it will be 15 mg per meter square, has to be given every 6 hourly for 8 to 10 doses.
Yeah.
15 to 20 mg per square.
When will you start giving it?
Yeah, I'll start it 24 hours after the methotrexate infusion.
Yeah. Methotrexate infusion, how will you give it?
Methotrexate infusion, I will ensure that there is adequate urine output and there is urine alkalinization.
Yeah. So what will your hydration protocol be for methotrexate?
So
How will you
before
give
giving
methotrexate and how will you give Leukeran rescue? So all these things I want to ask you.
so before giving MTX, I have to ensure 6 hours before that the patient is receiving adequate hydration. I'll give IV fluid, normal saline, 2 to 3 liter per meter square of the 2 to 3 liter per meter square of the body surface area, and there should be adequate urine output. I will add injection sodium bicarbonate 50 ml, which is equivalent to 50 ml, which is milli
Okay.
milli equivalent of sodium bicarbonate added in the normal saline, and I will keep giving it continuously, and I will ensure that urine pH should be in the range of 7 to 7.5, and I will keep doing the urine pH every 4 hourly, and also ensure that there is that there is intake urine output. And then when I attain a urine pH of 7 to 7.5, I'll start giving injection high dose MTX 12 gram per meter square. In the case of osteosarcoma, I'll cap it to 20 grams, and I will give it over 4 hours. And after giving MTX, I'll continue urine alkalization and adequate urine output ensurement I'll do. And then after 24 hours, I'll start leucovorin rescue, 15 to 20 mg per meter square every 6 hourly. I'll give for 8 to 10 cycles. And I will also want to know the therapeutic level of the MTX. Like in initial 24 hours, it should be 10 micromole per liter. Then 36 hours, 1 micromole per liter. Then 48 to 72 hours, it should be around zero point 0.1 micromole per liter.
Yeah. So less than zero point 0.1 after 48 hours, right? So I think you've perfectly mentioned it. I won't, he has mentioned regarding hydration that you need to start prior, 2 to 3 liters per meter square with sodium bicarbonate. Monitor the urine pH every 6 hours. Once you've given around 6 hours, above 6 hours of hydration and the urine pH is greater than 7.5, you start off with methotrexate 4-hour infusion. Following that 24 hours after methotrexate, you start a methotrexate infusion, you start with Leukeran 15 milligram per meter square. You give that 6 hourly. You monitor the serum methotrexate level, right? And then once it's less than zero point 0.1, then you can stop the leucovorin rescue, right? What is glucarpidase? What is the dose? What is the role? When is it given?
Glucarpidase is given in case of methotrexate toxicity when the levels, even after 72 hours, it's more than 10 micromole per liter. But I don't know the dose boss, never gave also.
Yeah,
No
so
idea.
I mean, no one, none of us have given it. It's very expensive actually. So it is a carboxypeptidase enzyme that breaks down methotrexate. It is given within 72 hours of giving methotrexate. It is only efficacious in 72 hours. It's given as 50, international units. As an IV infusion, and basically it is given when there is the serum methotrexate level is greater than one, right? So one is the cutoff, and there is renal toxicity or there's anticipated severe renal toxicity. So there it is given. Okay, so that is the indication. So it is given
So
as a
I have a
single
very
dose.
small question, when we give high dose MTX, then we have to ensure the pH should be 7 to 7.5, and at
Yeah.
times it doesn't come, we keep giving sodium bicarbonate.
Yeah, so
So are
if
there
anytime the pH falls less than 7.4 or 7, whatever cutoff you follow, you give bolus, 3 ampules of sodium bicarbonate. Okay.
any role of ENO? We also prescribe ENO sachets. No.
Yeah, I mean, some people do that. It depends on the institute. So stick to what is being followed in your institute. Okay. But definitely you have to say sodium bicarbonate. Okay. So that's that. Now let us move on. That is all these chemotherapy points you discussed. Super important. You should know it inside out. We are medical oncologists. Okay. You're not here to do any other business. So know your chemotherapy inside out. All these points we discussed, super important. What is the benefit of giving NACT in this setting?
NACT will ensure that patient may undergo a limb salvage surgery and will buy time for prosthesis if I'm planning limb salvage surgery and prosthesis. So by the time I'll give neoadjuvant chemotherapy, I'll buy out time, and it will help to eradicate the micrometastasis. And at the same time, it will also help me to know the inherent biology of the disease, whether the patient has got a good necrosis in the post-op specimen or not. So these are few things.
Yeah. So role of NAC, like you mentioned most of the points. So, you're addressing the micrometastasis. You are, assessing the tumor to, assessing the response to chemotherapy. You can know about the biology of the disease. then trying to prepare the prosthesis, right? So that was the initial indication for NACT. Then, of course, you have shrinkage of the tumor size, so higher chance for LSS, right? So also helps in performing LSS. How does it do that? It forms after you give an ACT, there's a reactive rim which is formed around the tumor in the form of calcified periosteum, which can give you an easier plane of resection while doing LSS post an ACT. So all those things are very important. Um, Now, surgical options, you described limb salvage surgery and amputation, right? Now, what are the contraindications to limb salvage surgery?
So,
What is the absolute contraindication, relative contraindication?
so absolute contraindication is if there is no power, the limb is not functional, then there is no point of doing a limb salvage surgery. Go ahead with amputation. That's the absolute indication, contraindication, sorry, for limb salvage surgery. If there is no power, there is no functional, if the limb is not functional.
Yeah, that's the absolute contraindication or relative ones.
Relative ones, like if the patient doesn't respond to neoadjuvant chemotherapy, and if there is involvement of the neurovascular bundle, if there is contamination, infection, abscess, or there is a fungating mass, and if the tumor involves multiple compartments, if there is a skip metastasis, and limb salvage. And if in a young patient, if the tumor is involving the epiphysis and the skeleton is not mature, then also there is no point of doing a
Yeah.
limb salvage surgery.
And one more thing, if they're present with, suppose there's pain and tenderness.
Yeah, if there's a pathological fracture.
Yeah, so that's also a relative contraindication. So absolute contraindications are non-functional limb. Relative is infected, ulcerated, fungating mass, neurovascular bundle encasement. There's a pathological fracture and presentation. If there's contamination of compartments, for example, if they did a improper biopsy, if the tumor size is increased after NACT, if the tumor is extending to the growth plate in a skeletally mature child, right? So all these are things, and you can also add extensive involvement of the joints. Okay. So those are important questions that definitely will be asked. Now, what are the types of processes that you use for limb salvage surgery? Can you just name a few?
uh, like we can use endoprosthesis in the form of a ECR50, we call it, like it's a endocondylar replacement. Then we can do autografting by using a fibula flap with a
Yeah.
common peroneal vessel. Then we can also go for a allograft.
Yeah. Yeah, so you mentioned
Uh,
all of them. So you can use something called a mega prosthesis. You can use auto or allo transplant of the bone. You can use an expandable prosthesis if it's especially if it's a very young child whose bones are not grown. And you can also use extracorporeal radiation, ECR50. So you remove the bone, you give 50 gray of fraction, 50 gray of radiation in single fraction, and then you reattach the bone, right? So all these are techniques in which you can carry out limb salvage surgery. Okay. So, I mean, that's another very important question. Now, before we move on, I want to just ask you, right? Okay, now you have done your NACT, you have done your surgery, and how will you assess response? That is necrosis. What are the classifications there, and what is the importance there?
So I will assess response. There are two criterias. It depends on the percentage of necrosis. Like there is a Hoover's criteria, and then there is a PC's criteria.
Yeah. So,
So
Pitchy and Hughes. Okay. So, what is Pitchy and what is Hughes?
so PCI is based on the percentage of necrosis. Like if it is total, then means there is no viable tumor on the tissue on the post-op specimen. If it is good, then there is at least 99%, 90 to 99% no tumor. If it is good, then there is good, then there is fair, which is less than 60 to 89%. Then uh, I will have to
Poor, which is
recall.
less than 60. Okay. So
Poor is
just remember one of them. So pitchy is total no total response, no viable tumor. Good is 90 to 99%. Fair is 60 to 89% tumor necrosis, and poor is less than 60% tumor necrosis. Also, you can look up HUOs. Just remember two names and remember one of the classifications. Important point here is that if it is less than 90% necrosis, the prognosis is bad. There's a higher chance for relapse. Okay, so 90% is the cutoff. Now, coming to, suppose you have not attained adequate necrosis in your NACT, you've done your limb salvage surgery, and there's less than 90% necrosis. Is there any evidence of changing the chemotherapy regimen post surgery? And what is the evidence for that? Will you change, and what is
So
the evidence?
so as per the Euromos trial, if in the poor responders they added ifosfamide and etoposide, it was associated with more toxicity, but there was no EFS or OS benefit. So there's no, even if it's a poor responder, there's no point of changing the chemotherapy. It's better to continue the same chemotherapy.
Yeah, so basically they gave in the poor responders, they continued with MAP or they added ifosfamide and etoposide to MAP, right? And there was no difference in EFS of adding ifosfamide and etoposide. So even in the poor responders, continue with the same regimen. There's no point in changing or adding other agents to that particular regimen. And evidence is a Euromos trial, like you rightly pointed out. Okay, so now if there's progressive disease on the biopsy or clinically, you should change the regimen. Okay, there's no doubt. Um, Progressive disease, you change the regimen. Now, moving on, um, what is the so you've done your surgery and then you've given your adjuvant treatment as well, right? You'll repeat 3 more cycles, or the pending, you'll go up to 6 cycles. Okay. So IAP, it's total 6 cycles. If it's MAP protocol, you finish the protocol, right? So that's how you treat it. So that's that. Now, some more questions that they can ask you in this setting. So if you get metastatic disease, suppose you get upfront lung mets, how will you treat this patient?
I will discuss with the operating surgeon if they can do upfront. They can do. I will give neoadjuvant, like if it could be, if it is a solitary mets or if it is in the range of resection, I'll treat it radically. If there are a lot of pulmonary metastasis, then I'll treat it in a context of palliative setting. Then I won't use triple drug regimen.
So basically, you're right. So discuss an MDT. There is no cutoff. There's nothing. It depends on what the surgeon is comfortable with, what the surgeon is willing to do. Okay. So discuss whether it is resectable. You give your NACT, then you reevaluate. If it is resectable, you remove the primary. You can remove the pulmonary as well, along with the primary, or you can do it in a staged manner after completing adjuvant chemotherapy as well. Okay. If it is unresectable upfront, you still give an ACT and reevaluate. And if it is continues to be unresectable, you can just treat with chemotherapy alone. And you might also do an address the primary if it is symptomatic. Okay. So always look at whether it's resectable or unresectable in MDT and give an ACT, look at the response, remove the primary and the lung mets along with the primary or in a staged manner after the adjuvant chemotherapy. Okay. If it is unresectable, then you have to treat it palliatively. So that is something that you need to know. What is the role of radiation in a case of osteosarcoma?
Radiation is indicated only if the margins are positive,
Yeah.
or even after resection, there is gross residual disease which is left behind.
Yeah. So margin positivity, although that we don't usually encounter that. If margin is positive, we go for amputation, right? So margin positivity, of course, extracorporeal radiation that I told in limb salvage surgery, you can also mention that here. And in palliative setting, you can give, right? So those are the indications. Now, very important question here that they can ask you is the evolution of treatment in osteosarcoma. This is one of those historical sites, right? And the old examiners, they get high on asking this question. So, can you just tell me, just very shortly, how the evolution of treatment in osteosarcoma was?
Like initially, there was Cadre's regimen, cyclophosphamide, actinomycin, then ifosfamide. Then there was Compadre's regimen, then added MTX, Compadre's regimen, then multi-agent chemotherapy in the form of high-dose MTX with BCD, bleomycin, cyclophos, doxorubicin came into picture. Uh, this is how it evolved. Like
Yeah. So,
cisplatin also came later on,
yeah.
got their role
You're
established
right. You're
later.
right. I'll just summarize it. So there's Cade's regimen initially. Okay. So Cade's regimen was you would give a high dose, 17 to 90 grade to the primary tumor, wait for 6 months. If there's no progression, then you amputate. Okay. That is how rudimentary it was earlier. Then you had single agent mitomycin, right? Single agent nitrogen mustards. Then you used VAC. VAC that was used in RMS, that is vincristine, dacnomycin, and cyclophosphamide was used earlier on. Okay, so that was changed to the Conpadre regimen. Okay, just look up what are the components of Conpadre. Then methotrexate, like you pointed out, was added. That was changed to Compadre regimen. Then they gave multi-agent, chemotherapy regimen, right? And this Jaffe and Rosen introduced high-dose methotrexate into the management. Okay, and later on they also found out that adriamycin and platinum agents were also important components. So that's how the MAP regimen was born. Then in MSKCC, they looked at neoadjuvant treatment and the benefits of neoadjuvant treatment, including time for, uh, you know, your processes preparation. And that's how neoadjuvant treatment was born. So that is the basic, how it evolved. Okay. So they might ask you that in the exam. Just be prepared with an answer if they ask you. So follow-up for this patient, I'll just quickly say, since you're running out of time, you do a chest X-ray, you do a local part X-ray, initially 3 monthly for first 2 years, and 6 monthly for the next 3 years after that, up till 5 years, right? Then annually. So, and of course, you need to look at, you look for recurrence, you look for late toxicity, like cardiovascular toxicity, metabolic syndrome, your autotoxicity, your neuropathy, etc. Secondary malignancies as well. So all this you need to look for while you're following up the patient. That is what they'll ask you. Now, quickly before we wind up, I'd like to discuss one more topic as well. That is Ewing sarcoma, right? Right. Someone asked me salvage regimen. That is not very commonly asked, but if they ask you that, you can mention a few regimens. So if you have not given high dose, if you given IAP, you can salvage with high dose methotrexate, right? You can give gemdosi, you can give ifosfamide and etoposide. You can also give multi-kinase TKIs if you're going for a palliative approach, like regorafenib, right? Regorafenib, cabozantinib, lenvatinib, etc. So all these are tried approaches, although most of them are not that effective. The main prognostic factor is how fast it relapses. So if it relapses within 2 years, poor prognosis. Greater than 2 years, you can still, if it's limited meds, you can still try to salvage with better outcomes, right? So like I mentioned, if you've not given high-dose methotrexate, give high-dose methotrexate-based regimen, gemdosi, ifosfamide, etoposide, multi-kinase TKI inhibitors, right? And timing of relapse is very important. So quickly, let's move on to Ewing sarcoma. Ewing sarcoma, I'll just quickly describe the workup is the same, right? You'll do a you'll do an X-ray local part, MRI, core biopsy. Metastatic workup, how do we proceed? Dr. Raja, please tell me. Very quickly.
Metastatic, again, HRCT of the thorax to rule out the lung metastasis, and then bone scan to rule out bone mets.
And also a bone marrow biopsy. Okay.
Bone marrow.
So that is what was done previously. CT thorax, bone scan, and bone marrow biopsy, because these are the three most common sites of mets. Now we can do a PET CT. Okay, so most people nowadays prefer to do a PET CT upfront that covers all the sites and has good sensitivity for all these metastatic sites. Okay, now moving on. In case of a Ewing sarcoma, histopathology shows a small blue round cell tumor, right? So can you give me other DDs for a small blue round cell tumor? This is a very important question that they'll ask you in your exam.
So I'll start with head and neck. In the brain, first is medulloblastoma, pineoblastoma, then retinoblastoma. Then in the head neck, it's rhabdomyosarcoma. Then small cell carcinoma, come to the thorax. Then abdomen hepatoblastoma, neuroblastoma, nephroblastoma. Then extremities, Ewing sarcoma, and melanoma, synovial sarcoma, lymphoma.
Good. You have mentioned most of them. So just be prepared with an answer. They'll ask you what are DDs of small round blue cell tumor. You should be prepared with an answer. So one mnemonic is Mr. Sleep. M is for melanoma. R is for RMS. S is for sinonasal sarcoma that can be seen. L is for lymphoma. E is for esthesioneuroblastoma. Second E is for Ewing sarcoma and peanut. Then P is for pinealoblastoma. Then, of course, the other tumors, medulloblastoma, nephroblastoma, neuroblastoma, etc., can also be involved. In lymphoma, sinonasal sarcoma can also be involved. So just remember that. Be ready with your DDs, okay? When they ask you small blue round cell tumor. Okay. Now, coming to what are the IHCs that are commonly positive in an Ewing sarcoma?
Most specific will be CD99 positivity. MIG2 positivity.
And recently, what IHC markers come that is highly sensitive and specific? So it is a NKX 2.2. Okay, that is,
NKX 2.0.
yeah,
Sorry.
that is also highly,
NKX is in it is in prostate. Okay.
yeah, this is
Let's
NKX 2.2. Okay. So
okay.
CD99 is also confusing because there are other cancers that are partially CD99 positive. So you need to remember those. Okay. So I'll just quickly tell you. So lymphoblastic lymphoma, rhabdomyosarcoma, synovial sarcoma, desmoplastic small round cell tumors, solitary fibrous tumor, clear cell sarcomas, all these are partially CD99 positive. It can be an added DD despite being CD99 positive. That's why you use NKX 2.2 that is more specific towards Ewing sarcoma. Okay. Um, Now, uh, what are the common? So, for Ewing sarcoma to on a molecular level to establish it, what is classically done?
So we'll do the molecular testing in the form of translocation, which is
Yeah, yeah. Please tell me.
we'll do molecular testing in the form of translocation. So in Ewing sarcoma family tumors, this ETS and FET family translocation happens. So the most common we find is the EWSR1, Ewing sarcoma replication protein 1 with FL1, FLI1, friend
Yeah,
leukemia integration 1. That is seen in 85% of the patient. And in other patient, there could be EWSR1 fusion with the ERG and also EWSR1 fusion with ETV1, ETV4, ETV6,
yeah. So
which
these
is
are
in
a
less.
typical Ewing
85% is
sarcoma case. This is what you'll see, right? And to that question I asked earlier, you use classically we use break apart fish, right? So there, if there's a EWSR1 mutation with the unknown partner, we can detect that. Although we won't know the exact partner, right? Currently, we use NGS. There, we can know the partner as well, which can give us more information. So there's Ewing's like sarcoma as well, and atypical Ewing's. Can you tell me what these are very quickly?
thing like sarcomas are they have morphologically they mimic like Ewing's only, but there is not the typical ETS and FET fusion like BCOR, BCOR sarcomas, CC1 sarcomas, and in case of Ewing's, like there is marked for, matlab, there will be no fusion between the typical fusion we won't find, but morphologically they'll mimic like Ewing's,
Yeah.
like they
So
have some different mutations.
yeah, so the Ewing's like sarcoma that can be if there is no FET component, right? So that EWSR1 component is not there. FET component is EWSR1 component. So that can be BCOR CCNB3 type, BCOR ITD type, cis DUX4 type, etc. Right? Then there can be Ewing's like sarcoma where there's FET component is there, but there's no ETS component like FLI1 or ERG, right? So that is EWSR1 NFAT-C2, EWSR1 SP8, EWSR1 PAT is at 1. So just remember two names, okay? And know what it is. So either no FET component or no ETS component. Okay. Atypical Ewing sarcoma is fusion between FUS ERG or FUS FEV. So those are the common types, atypical Ewing sarcoma. Okay. So Ewing's like sarcoma, atypical Ewing sarcoma. Just remember that. Now, what is the treatment protocol for a case of Ewing sarcoma? What do we do?
We use multi-agent chemotherapy in the form of compressed 2 weekly VDC, followed by alternating with ifosfamide and etoposide regimen.
Okay. What is the duration? Where do we incorporate local therapy?
So we give initially for 6 cycles the compressed regimen, 2 weekly VDC IE, and after 6 cycles we'll assert for local therapy, be it surgery or radiation, and after that we'll complete 8 more cycles, total 14 cycles.
Yeah. So I'll just reiterate. We, like you said, we give VAC, that is vincristine, adriamycin, cyclophosphamide, alternating with ifosfamide and etoposide, right? You ideally should give it 2 weekly. There's an OS benefit. If not possible, you give it 3 weekly. At week 9, that is after 3 cycles. Okay, 3 to 4 cycles. Between week 9 to 12, you give the local treatment. Wherever possible, you should do surgery, right? If surgery is not amenable, for example, say it is a site where pelvic site, for example, surgery is not amenable, you can give radical RT. Sometimes if surgery is done and if there's margin positivity or if there's less than 90% necrosis, you can also give adjuvant radiation. Okay. So that is given from week 9 to 12. And then you complete total 17 cycles. Whether you're giving it 2 weekly or 3 weekly, you complete 17 cycles. Now, can you tell me the dose for the VAC regimen?
The dose of vincristine is 1.5 mg per meter square. Adriamycin is 75 mg per meter square, can be divided into 37.5 day 1 and day 2. And cyclophosphamide is 1200 mg per meter square, day 1. And in ifosfamide, etoposide, both the drugs are given for 5 days, 3 weekly. Ifosfamide is 1800 mg per meter square, day 1 to day 5. Etoposide is 100 mg per meter square, day 1 to day 5.
Yeah, very good. So that's how you give it. And suppose you give vincristine and the patient complains of severe pain and erythema at the site of infusion. Uh, what are the specific, don't mention all the steps again. What are the specific things that you'll do in vincristine extravasation?
I'll do warm compresses, specific measures, and I'll try to
So DNA, non-DNA binding vesicant, right? So warm compression. So you try
and
to
dilute first method, the
dilute it.
dilute and dilute hyaluronidase cream can also be used.
Yeah, right. So you get 1,500 international unit bottles, 10 ml. So for every 1 ml of extravasated thing, you add 1 ml of hyaluronidase. You give it subcutaneously in an insulin syringe. Okay. So that's how it's done. Now, like you said, if possible, 2 weekly, or this you give 3 weekly. Now, another thing that I need to ask here is, during radiation, what regimen do you give? How do you change? You give concurrent chemotherapy with radiation, right? So how do you change the delivery?
Yeah, no idea.
Yeah, so
When Kristen,
you either give, you know the answer. I don't think you understood the question, but I'll just tell you because of lack of time. Ifosfamide and etoposide is usually given concurrently, and if you're giving VAC, you should always replace adriamycin, omit adriamycin because that can cause.
radiation recall phenomenon.
Yeah, exactly. So radiation recall phenomenon can be there. So if you want, various institutes use various techniques. So some people give ifosfamide etoposide along with that, but some people say that can cause severe myelosuppression, especially when given with radiation. So other people choose to give VC alone. They omit adriamycin. Otherwise, there can be skin toxicity at the site of the irradiated site. That is called radiation recall syndrome. It is commonly seen with adriamycin. Okay. So moving on. What is the cardiac cutoff for adriamycin in Ewing sarcoma?
Yeah, as per the in the trial of intergroup 0091, the cumulative dose were level 375 mg per meter square, I think.
Okay.
Not
What if the patient is receiving chest wall RT?
chest wall RT, it's 250. No, I'm not sure. 250. I'm just making a guess.
Yeah, so it is 300. Okay, so chest wall RT is received, it's 300 milligram per meter square, and otherwise it's 375 milligram per meter square. What is the drug you'll use to replace
Yeah.
adriamycin?
After the cumulative dose exposure, I'll replace adriamycin with dactinomycin.
Dose?
1.25 mg per meter square, 3 weekly.
Okay, good. If it's part of 2 weekly protocol, otherwise 3 weekly, right? And one more thing to note here is that when you give the VAC regimen, you should always give a high level 4 anti-emesis protocol. You should always give primary prophylaxis as well. Okay. Both VAC and IE, primary prophylaxis, because there's a greater than 20% chance of febrile neutropenia. Okay, that's something else to note here. Now, before we wind up, right, so we've discussed, I think, most of the important points there. Suppose the patient develops CNS toxicity to ifosfamide. What can we do there? And we cannot give ifosfamide again.
We can discontinue ifosfamide. After giving this methylene blue and thiamine, we can discontinue to give ifosfamide, or we can substitute it with cyclophosphamide.
Yeah, very good. So you can substitute with cyclophosphamide 1.5 grams per meter square. Okay, that is another thing that we can do. If you get Ewing sarcoma with lung mets, what do you do?
I'll continue the chemotherapy and also go for a lung bath.
Yeah, so you can either resect the as part of local treatment, you can resect the lung mets and follow it up with lung bath, or if it's
Lung irradiation.
unresectable, you can give NACT if there's good response. Then you can, along with resection of the primary or primary RT to the primary, you can also give lung bath, right? If it's unresectable, if resectable, go for resection. So that is another option there. And in fact, it's if you address it radically, it's found to improve survival. right? But what are the patients that are unresectable, that are unlikely to be resectable? What is the treatment there?
Mm, Same multi-agent chemotherapy.
Yeah. So there you don't give IE
I
alternate. You can
yeah,
continue with VAC only.
back
Okay.
only.
There's
Yeah.
no benefit of alternating with IE. Okay. Now, what are in recurrent having sarcoma? What are some of the protocols given? Quickly, we'll just wind up now.
Recurrent, even we can give ifosfamide etoposide if the patient has not been challenged initially. Oh, you're talking recurrent.
Yeah, recurrent.
We can give gemcitabine, docetaxel. We can
Okay.
give
Yeah, so we can give high dose ifosfamide alone. We can give cyclophosphamide plus topotecan. We can give irinotecan plus temozolomide. Okay, those are some of the regimens. You can give gemcitabine and docetaxel. So those are some of the regimens used. Uh, yeah, so that's it regarding Ewing sarcoma. If you want to score really well, you can also study the Euro Ewing 2012 trial. Okay, earlier in Europe they were treating Ewing sarcoma differently. They were giving this wide regimen, but in the
right.
Euro Ewing trial they found that VAC-IE is the best regimen. Okay. And role of high dose chemotherapy and autologous bone marrow transplant, it's usually done in the recurrent setting, right? And the evidence, the outcomes are kind of poor still. Okay. Basically, basic funda is once Ewing sarcoma recurs, the outcomes are poor, whatever you try. And it's unlikely that you will cure the patient in the recurrent setting. That's why we go full, all balls to the wall approach in the upfront setting. Okay. In some of our institutes, we give 3 weekly, some of it we give VAC-IE 2 weekly. Okay, 17 cycles, local treatment, week 9 to 12, either with primary surgery, if not possible, primary RT. If surgery, the indication is there, you give post-op RT in margin positive setting, or if necrosis is less than 90%. Okay, so I think that covers everything. Bone sarcomas, these are the only points they will ask you. I'm very confident, unless some examiner wants to be an ass to you and ask you something else. But thank you, Dr. Raja. You did an excellent job.
Thank you,
Uh,
boss.
I was very hard on you, but still, you are my junior. I was very hard on you, but still, you did an excellent job.
Thank
Okay,
you.
so you'll do well for the exam, and all of you remember these points. Good night. See you all.
Good night, boss. Thank you so much.